Assalamualaikum. Today our group is going to explain about methotrexate versus leflunomide, the content being drug profile, patient counseling and drug interaction, followed by the conclusion at the end. My name is FIRDAUS FARHAAN bin NORHAZLI with student ID 20244278866. I'm from group D1 and this is my group members. This is the drug profile for methotrexate and also the leflunomide. This is the general information, by the way. You guys can pause the video if you guys want to read into it. So, this is the drug classification. Mechanism of action for methotrexate. It inhibits dihydrofolate reductase DHFR, leading to decreased tetrahydrofolate levels, which are essential for DNA synthesis and cell replication. Inhibits ICAR transformylase, resulting in the accumulation of adenosine, a molecule with anti-inflammatory properties. Suppresses T cell activation and cytokinin production, contributing to its immunosuppressive effects. For leflunomide, it converts to teriflunomide, which inhibits dihydroorotate dehydrogenase (DHODH), a key enzyme in de novo pyrimidine synthesis. This leads to reduced proliferation of activated T and B lymphocytes and decreases auto-antibody formation. This is the therapeutic indication for both methotrexate and leflunomide. You can also pause the video if you guys want to read into it. For patient characteristics suited for these drugs, obese patients are suited for both drugs. However, for pregnancy and elderly patient, it requires special consideration. And do remember to not avoid both methotrexate and leflunomide for pregnancy patient. Patients with early onset rheumatoid arthritis are suited for both drugs. Also suited for both drugs for patients who cannot afford biologics. Patients with moderate to severe rheumatoid arthritis are most ideal candidates. This is the pharmacokinetic summary for methotrexate. I have included the absorption, distribution, metabolism, excretion, and also half-life. You guys can pause the video if you guys want to look into it. This is also the pharmacokinetic for leflunomide.
Assalamualaikum warahmatullahi wabarakatuh. My name is MUHAMAD bin NOORDIN, number ID 20242999482. I will be talking about clinical consequences for methotrexate and leflunomide. Methotrexate available in tablets and oral solutions, single-dose vials or prefilled syringe injectables. Leflunomide only available in oral tablets form. Methotrexate and leflunomide available strength is in this slide. You can read the HARITH description. This is another example for them in picture format. Therapy duration for methotrexate focus on rheumatoid arthritis, polyarticular juvenile idiopathic arthritis, and psoriasis dose. And discontinuation of it may cause RA to resurface. Meanwhile, leflunomide focus on the onset, dose, loading dose, and the consideration, as well as elimination process. This is the continuation of it. Both methotrexate and leflunomide can be administered concurrently with each other to treat chronic rheumatoid arthritis. Adverse effects for methotrexate is liver function test abnormalities, burning of skin lesions, stomatitis, vomiting, headache, photosensitivity, and others. Management for methotrexate focus on pregnant women and advisory for patients to call their healthcare provider. The continuation of it. Leflunomide adverse effects is Stevens-Johnson syndrome, toxic epidermal necrolysis, and drug reactions with eosinophilia and systemic systems, interstitial lung disease, bone marrow suppression, peripheral neuropathy, and others. Meanwhile, the management focus on embryo fetal toxicity, nursing mothers, and others. Contraindicates. Methotrexate and leflunomide both contraindicates pregnancy and hypersensitivity. Meanwhile, methotrexate focus on nursing mothers, alcoholism or liver disease, immunodeficiency, and pre-existing blood dyscrasias. And leflunomide focus on patients with hepatic impairment history, patients that are undergoing teriflunomide therapy. This is the storage and handling for methotrexate, and this for leflunomide. Methotrexate has a total of 726 interactions, and minor, moderate, major food interactions is warfarin, zoledronic acid, aspirin, and caffeine or alcohol. Leflunomide has a total of 680 total interactions, and the minor, moderate, major food interactions is elderberry, glimepiride, abacavir, and alcohol. That's all from me. Thank you very much.
Hi, Assalamualaikum. I am Muhammad ZAFRAN with Muhammad HARIREE from A1. And I will continue with drug interactions. How MTX and leflunomide combination therapy works. As we see, rheumatoid arthritis is like wildfire in the joints. So, leflunomide acts like a thin spraying foam that smothers fires by cutting off their full supply. It blocks pyrimidine synthesis, which these cells need to multiply. Then, methotrexate works like a fire crew using water hoses. It targets the core fire, slowing down the immune system by interfering with folate needed for rapidly dividing immune cells. Why the combination is better? First, different targets promotes broader immune suppression. MTX and leflunomide inhibit different metabolic pathways. This dual action reduces inflammation more effectively than either drug alone. Second, exert additive and synergistic effect. Because both drugs act on different immune mechanisms, their combination leads to the greater symptom control. Third, helps when monotherapy fails. When patients don't respond well to enough methotrexate alone, adding leflunomide can rescue these cases and lead to better disease management. A study has been done to prove the efficacy of combining both drugs. As a quick conclusion, adding leflunomide to methotrexate therapy in RA patients significantly improve clinical outcomes but needs a careful monitoring on patients due to the powerful immune modulating drugs. Then we go into key drug interactions and risk. First, hepatotoxicity, the most significant interaction. How do we monitor it? First, liver function test every 2 to 4 weeks initially or discontinue one or both drugs. Second, bone marrow suppression. Risk of additive myelosuppression leading to leukopenia, thrombocytopenia, and anemia. CBC, complete blood count every 4 to 8 weeks. Folic acid supplementation with methotrexate helps reduce the risk. Third, increased risk of infections. Both drugs suppress immune function. And how do we monitor? Patients need to screen for latent TB, hepatitis B or C before starting. Then, pulmonary toxicity. Both drugs have been individually associated with interstitial lung disease. Lastly, teratogenicity. Both drugs are teratogenic. Absolute contraindication in pregnancy. So, strict contraception required during and after discontinuation. So, that is all for drug interaction. You can click the link for further reading. Thank you.
Hi, Assalamualaikum. My name is ILHAN. The name is Harith. I'm from C1, and I will proceed with the conclusion part of the slides. In conclusion, both methotrexate and leflunomide are essential disease-modifying anti-rheumatic drugs commonly used in the treatment of autoimmune diseases such as rheumatoid arthritis and psoriatic arthritis. Methotrexate remains the gold standard due to its proven long-term efficacy. At the same time, leflunomide offers an effective alternative, especially in patients who are unable to tolerate methotrexate or require additional symptom control. Both drugs have distinct mechanism of action. Methotrexate targets folate metabolism, whereas leflunomide blocks pyrimidine synthesis, allowing for complementary effects when used in combination. Combination therapy has shown greater effectiveness in managing symptoms for patients with inadequate response to methotrexate alone. However, this benefit comes with an increased risk of adverse effects, particularly hepatotoxicity, bone marrow suppression, and infections. Therefore, careful patient selection, regular monitoring of liver function and blood, and strong patient counseling are critical to ensure safety. Both drugs are contraindicated in pregnancy due to the teratogenic effects, requiring strict contraception and drug washout protocols before conception. Additional care must also be taken with elderly patients and those with underlying liver or kidney conditions. Ultimately, treatment with methotrexate, leflunomide, or a combination of both should be individualized based on the patient's condition, tolerability, and access to therapy. With proper monitoring and counseling, both drugs can significantly improve the quality of life for patients living with chronic autoimmune diseases. Here is the links for our references. Here is the evidence of teamwork. I think that's all from me. Thank you and have a great day.